We're live. Welcome everyone to our Streaming for Survivors panel. Thank you for your patience with all of our tech. Today's panel topic is dreaming of intersectional feminist healthcare. What would that look like? My name is Jocelyn, and my pronouns are she and hers. And I am coming to you this morning from the unceded and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh people, colonially known as Vancouver. Salal Sexual Violence Support Center is honored to live, play, and work here alongside Indigenous community, and we are thankful to these nations for stewarding this beautiful land since time immemorial. I am very excited to be amongst people from across Turtle Island today and encourage everyone to explore whose lands they are on and support land back movements within your own communities. To introduce myself, I am the Victim Services Coordinator here at Salal, and I'm very excited to be your moderator for this discussion. In today's panel, we will be diving into a conversation about the current healthcare system and how an intersectional feminist framework would improve the gaps in care for marginalized folks. I have a couple of housekeeping points before we begin. We will not be taking questions from chat this afternoon, but we still encourage people to engage with the conversation respectfully in chat. If you learned something or feel moved to support survivors and join Salal on our journey to create a future free from violence, please consider making a gift. The donation link will be featured in the chat, along with resources like our 24-hour crisis and information line and our website. So we will start with a round of introductions, and if everyone could please share your name, pronouns, social media handles if you feel like sharing, and a land acknowledgement if you feel comfortable sharing that as well. So Tenzin, why don't we start with you?
Hi, everyone. My name is Tenzin Putsong. My pronouns are she and her. I'm very happy to be joining you today virtually from the heart of Chief Dry Geese territory here in Yellowknife, Northwest Territories. I'm a Tibetan settler. I was born on and raised on unceded Coast Salish territory, and am also a PhD candidate at the University of Toronto in the Dahlana School of Public Health. But I'm currently a research fellow with Cleachon Government here in the Northwest Territories.
Sheila, I'll pass it to you.
Good afternoon, everyone. Thank you for inviting me to be part of this panel. My name is Sheila Early. My pronouns are she, her, and I work on Turtle Island, which also known as North America, but I live and play in the Kwantlen, Kazi, Semiahmoo territory, which is known as Surrey, British Columbia. I am a forensic nurse, consultant and educator for the past 30 years, as well as founder of the Canadian Forensic Nurses Association. And that's it.
Thanks, Sheila. Dahlia, I'll pass it to you.
Thanks, Jocelyn. Hi, everyone. My name is Dahlia. I use she, her pronouns, and I am joining today from the unceded and ancestral territories of the Musqueam Nation. Had the pleasure of going and being with the water today on the Fraser, and so much gratitude for Musqueam for taking care and stewarding these lands. And I am the executive director at Salal, and I'm going to channel all of my victim service medical support worker energy that I originally came to this organization into in 2005, and I'm really excited for this conversation. Thanks.
Amazing. Thank you, everybody. So we'll just dive right in. Our first question this afternoon that I want to ask all of you, what does feminist anti-oppressive care look like to you? And is that reflective of our current medical system? So anyone who'd like to answer first, I invite you to jump in.
Sheila, do you want to start us off?
Sure. Yeah. Many things come to mind. I think that I've been in healthcare for 55 years, so I know the good, bad, and the ugly. And I think part of what has happened over the past 30 years is that the focus on wellness for the population of Canada has continually been eaten away politically and financially. And there's care going on across the spectrum of life, from birth to death, that is very disconcerting for healthcare providers. It is also unacceptable in many situations. And I think as a population, we have become complacent, so that we have not reacted um, strongly enough to the first changes that started happening. And then suddenly 20 years ago, the Canadian Nurses Association said that there was going to be a shortage of healthcare workers. Well, guess what? It started happening a long time before the current crisis. Is it reflective of the current medical condition system, rather? Yes, but I think more so to the the politics and the financial support for healthcare. I think the medical, and when I say medical, I don't mean physicians. I mean the whole healthcare system. We were taught to make do with what we had, and we didn't ask for things when we should have. And now today, and I'll jump into today, is that not only do healthcare workers need to unite strongly, and in some instances that is happening, but it has to also be a collaborative effort with the community. The community has to stop accepting what is not there. And the only way that the whole care for every individual is going to change is when we speak out. There's a saying, and I'm going to paraphrase it. Well, I didn't have diabetes, so I didn't worry when they made diabetics pay for their needles and their insulin. Well, I don't have this disease, so it doesn't matter to me. And I'm not in childbearing age, so it doesn't matter about contraception. I also want to make to say this could be said for everything. And unfortunately, one day you wake up and it's you having whatever medical emergency that can occur, and there are many. And then society says, "Oh, gee, that's really too bad. It's on the news and everybody gets concerned." But it stops there. So when we look at the feminist approach, it needs to also be collaborative with that healthcare system and say, this is what we can help you with. And then healthcare can say, this is what we can help you with. Yes, let's move things out to the community if that's the best. But it has to be, right now I still see silos and lack of communication, and more importantly, lack of understanding between community, healthcare, the professions, victim services, gender-based violence, people with disabilities. I fought for 4 years to get the building where my husband could no longer go to the dentist because of 3 flights of stairs, and the building owners refused. So there's so many other things that can be done, and I think that this is a very good opportunity for sharing and communicating and collaborating. It's not what you can do for me, it's what we can do for each other. Thank you.
That's great, Sheila. Thank you.
I guess I'll just jump in there. I think something Sheila mentioned just jumped out to me in terms of thinking about feminist, anti-oppressive care. We think about accessibility and thinking about the broader, movement around disability justice. And I think for me, feminist, anti-oppressive care is really, a collective work that brings together, many different movements from disability justice, from environmental justice to issues around housing justice, and really just ensuring that those connections are being made. And I think at at the whole, like around anti-oppressive care, really meeting people where they're at and adopting those principles in healthcare. You know, that notion of really being able to work collectively towards this common goal for public good, and really kind of embodying those principles around humility, cultural safety, you know, especially, you know, when we're thinking about at the provider and like individual levels, like self-awareness, you know, critical self-reflection, especially when those power imbalances are so salient in the healthcare system, and really taking a holistic perspective, and I think that is kind of you know, comes through with meeting people where they're at as well, but understanding, you know, all these different aspects of people's lives, people's histories, and also, you know, historical intergenerational issues that are also present and that still have like ongoing impacts and effects on individuals and communities. Yeah.
Thank you both so much. Lots resonate for me as well. And I guess I would just say that I typically have the opinion that our system does not reflect a feminist, anti-oppressive care structure. And I'm a bit of a historical sociology nerd, so I always like to think about how our systems have been built and what the morals and values have been in creating those systems. And I'm very cognizant of the fact that the medical system, similar to other systems, like the carceral and criminal legal and policing systems, have been by and large built on ideas of inequity, and have also been used to, to harm people, right? We have a history in Canada of Indigenous folks being researched on and tested on against their will, and those things also persist around the world. And so, without also looking back to understand where we are now to look forward to create something new, it becomes really challenging. So I think I've been really moved by the In Plain Sight report, that I would really encourage folks to read if you haven't yet, but just the deep racism and particularly the anti-Black and anti-Indigenous racism that is so alive in our systems creates a really challenging reality for folks to feel like they can even access our care systems, and whether that's after experiencing gender-based violence or sexual assault, or just going in to get care. We were in a conversation the other day with some trans folks that we work with, and they were talking about, similar to what I've also heard fat people talk about, which is like oftentimes folks go in for care about a broken arm or, something like a skin condition, and their fatness or their transness gets blamed for those things that are happening to them. And so I think if we're dreaming forward and thinking about what does feminist anti-oppressive care look like, it really means being awake to all of those systems and how they're influencing the ways in which people are receiving care. And, asking ourselves as practitioners in these systems whether we're able to like offer people their full humanity and dignity in the way that they're showing up and asking for care and support.
Yeah, thank you all for your amazing insights. I think I'm someone with a social work background, and something that really resonated with me with everything that you were all saying was how a big thing is like the social determinants of health, and how those typically are not considered within the medical complex, the industrial complex that we have in place. And a lot of times it falls on the backs of, allied health or other support workers to address those things. And it doesn't necessarily go into like a holistic view of care that is necessary, and we know is also a decolonial way of approaching healthcare too. Um, So thank you all. And that kind of leads into our next question. What influence does a holistic view of healing have, and what is Salal doing to support this?
Sorry, is it me again?
You can jump in, Sheila. Yeah, of course.
Okay. Okay. Just one comment about the first question is that in 2000, um, the World Health Organization published a World Health Report, and that's 24 years ago. And what it said was violence. It didn't define any particular entity. It said violence is a healthcare issue. So that is a mandate that has not been met in any country that I'm aware of. That treating violence in all shapes and forms is a part of the healthcare mandate. That's still 20, they say it takes a generation to change. Well, I'm not sure we can wait a generation. How that comes in with the holistic approach is that I think one of the things about healthcare is change comes very slowly. And 20 some years ago, healing processes were integrated into healthcare with the patient slash client's choice. It became part of healthcare. The problem is people don't know to ask. And it's, so that, and there, many nurses took holistic therapies and could provide it, especially in palliative care and oncology. And so there is a place for the holistic look, but it hasn't gone into mainstream healthcare. So what does this mean? It means that we all still have to go back and say what the individual needs may not be what the healthcare provider thinks, and they need to go back to what is the choice of the individual. I've been a nurse for 55 years, so I'm quite used to telling people what to do. However, as a forensic nurse, which is caring for victims of violence and trauma, mostly sexual assault, domestic violence, intimate partner violence, child abuse, etc., the choice goes from me as the healthcare provider to the individual. And that's the difference that has kept me in forensic nursing for 30 years. Because the choice is no longer on me. Because what if I make the wrong choice? And when you support someone, you support them for all their needs, their mental needs, their psychological needs, their physical needs, their spiritual needs, and all their biopsyche needs that go along with it. So that means going back and bringing holistic viewpoints back into the education of not just nurses, but physicians, all healthcare providers that work within the system. It should be available. And is it going to be? I honestly don't know. I think it becomes up to the individual practitioner what they educate themselves in. Long-winded reply, I apologize.
That really resonates with kind of how I view, holistic healing. And I mean, to answer to give my answer to that specific question, like what influence does a holistic view of healing have? I think it's transformative, and in the context of the current, medical system, it's radical. And if we really looked at all of the different dimensions of health, like Sheila mentioned, emotional, spiritual, physical, mental, and not just, we're siloed into addressing, specifically physical health issues or mental health issues, but also considering, these other, we talked about social determinants a little bit earlier, looking at, education, at, and specifically when we think about Indigenous communities and like self-determination and governance and the economy and like capitalism and, resource hoarding and all of these different dimensions that ultimately also influence health, and kind of consider it as a whole rather than as these separate issues that have relevance, but aren't necessarily things that need to be addressed together. Um, if we kind of understand it from that more, decolonial perspective, it's only, you know, only transformation and really radical change that could come of it. And something I really think about when I think about like what it actually means to adopt a kind of holistic perspective is some of the work I do is with previously incarcerated mothers, Indigenous mothers, and when we think about when I speak to them about their time in prison or interactions with the child welfare system, they will share things about how it's impacted their mental health and even having lack of access to healthcare in prisons. But then there's also those elements that you can't necessarily just you can't just tie easily into like a physical health issue, like the the experience of having your child forcibly removed from your care. That's something that most certainly impacts your health, your wellness, um, and is something that if you can't describe in those other dimensions, then how can you really describe it? So that's how I think about things like spiritual and emotional health as well. And yeah, and moving away from these kind of, our traditional biomedical um, Western notions of health.
Beautiful. So inspiring. I think two pieces that resonated from both of you is one that I'm always challenged by the fact that sexual violence gets seen as only a law and order issue. And so Sheila, what you were saying about the UN, stating that violence is a healthcare issue is such an important piece. And I think one that we deeply believe at Salal, about how people should be able to receive holistic healthcare that understands the full picture of what people are experiencing after sexual violence. And then Tenzin, I was thinking about as you were talking, like the medicine wheel was just like in my head, and just how so many cultures around the world have ancestral teachings around our wholeness, and how we have to be able to weave all parts of ourselves together in order um, to move towards healing, right? And if our healthcare systems are intended to support us to thrive and continue on with life um, and be able to take in all aspects of life, then it only makes sense that we would be attending to those spiritual and emotional aspects and not just band-aiding one part of a body and then not trying to change again kind of the conditions that have maybe led to that piece needing attention, right? And I think about how lucky I felt having a midwife during my pregnancy, and just how being with somebody that really saw me as a whole person during that whole process was essential to my care, and how much of that also those teachings that midwives hold are so deeply rooted in like long time knowledge of old ancestral teachings. So I just think it's so important. There's no survivors that I've ever worked with over the past whatever 19 years that I've been doing this that don't have so many things that are being woven into their experience with the medical system, with their bodies, with their health. And it's one of the reasons why we're really excited to be opening our integrated sexual assault clinic, with the short-term view of being able to support folks in medical aspects after an assault, but with a long-term view of really creating healthcare for survivors throughout the lifespan. because we know that, the impact of sexual violence can have really long-lasting effects on folks throughout their life. So, yeah, thank you both.
Yeah, I think what I really got from what the three of you were sharing was really that shift needs to happen away from the kind of the focus and we place so much importance on Western ideas of medicine, and I think the importance of decolonizing that idea and moving into holistic practices that have existed long before our current medical system. So thank you all for sharing. And in terms of our next question, I would love it if you would all share with us some new ways that the medical system is expanding outside of the medical industrial complex. So, for example, things like death doulas is one way that is shifting. And why is this important? I'm going to switch up the order a little bit. So, Tenzin, I'm going to start with you, if you could share that with us.
Yeah, sure. So I really want to hear more about death doulas because that's not something I'm super familiar with. But something that I think about often is, um, I mean, at its core, a lot of community work, community-driven healthcare, mutual aid work that has just blossomed so much over the last few years, and things that exist outside of the system. One of the things when I was reading this question and thinking about this question was something that Leanne Simpson wrote, which was, this is probably butchering the quote, but essentially that engagement with the settler colonial system really changes you more than you can change it. And so that's the kind of approach I had to thinking about the ways in which I've seen really like community-driven health being provided to people who are experiencing homelessness in Toronto. There's an organization called Street Health, and they do, provide harm reduction services and really center their work around people who've experienced homelessness, and kind of adopt, in the ways that they can, because obviously there are so many challenges with smaller community-based organizations that they face in terms of resourcing and just being able to provide that same outreach that longer, larger arms of the medical system can as well. But really being there to support people and meet people where they're at, on the streets, and providing that level of like anti-oppressive care, and with the judgment-free care and services, especially around drug use, that are often very, very prevalent. So yeah, that was one of the things I was thinking about in terms of all of this, the community-driven work that's really, really existed, not just over the last few years, but has always resisted as long as there has been resistance and activism and advocates out there, who recognize all of the issues that are in the existing system. So yeah.
Well, I have the luxury of looking back over the last 50 years, which I was probably before all of you were born. So I can see the changes that have happened within the healthcare system, and but I think it's more importantly to say why they changed. They usually changed because of one person or a small group of people saw something that the rest of healthcare didn't see, and that is true for myself. In 1992, I'd been an emergency nurse for 30 some years. And at the time, I was the educator in Surrey Memorial Hospital here, which is the largest volume emergency in Western Canada. It still is, by the way. And a sexual assault, person who had been sexually assaulted had come in on a night shift and had waited for a long period of time. When I came on in the morning, I was asked to follow up on a complaint by a police officer that he felt that this woman was not treated appropriately because she had to wait for care. This is 1992. As a result of that one single complaint by an RCMP officer, I developed the forensic nursing program at Surrey Memorial Hospital, which changed totally healthcare provision in British Columbia and actually eventually across Canada. Why? Because it specified a specially educated individual to care for one person at one time and meet the needs that were apparent at that time. So when we're talking about all those different areas that I talked about before, that was the goal of the forensic nurse examiner. It wasn't called forensic nursing at the time because nobody knew about it, that there was such a term. So that had actually has changed the face of healthcare in Canada. And I'm probably the most proud of that, except for my two children and my 4 grandchildren. So what I'm getting at is it needs a champion. Who championed injection sites in Vancouver? Nurses and individuals, and said, no, we can do this too. It also became a template. The care for HIV across North America originated here in British Columbia. Again, somebody saw something that wasn't right. So when I look at how the medical system is still continuing to change, is your outreach programs, home care. When we're talking about violence and trauma, we also look for where are the follow-ups, and that's the piece that's missing. There isn't enough follow-up. Now, is that healthcare's issue? Perhaps, but regardless of whose responsibility is, it needs to be done collaboratively. And don't get me wrong, community has a huge importance. I work for volunteer for a community agency that is doing wonderful work for the past 14 years. And in just that, doing things with no money. Unfortunately, that should not be the way it is, but it is. So when we look at medical system and going outside the doors, which is what I presume what that means is the industrial thing, is the doors have to open both ways. Community has to come in and medical care has to go out, because you cannot care for individuals without both. Now, I'm for example, not only part of the forensic nursing program at Surrey, and I apologize because it's still a template across Canada, is they developed an Embrace clinic, which is an aftercare, after medical care. Okay, it was a dream of mine way back. It finally came into being. But there are situations where the physical injuries are hugely impactful. And we have to remember that community may not be able to address those. And when I say that, think about the changes that are now being recognized within healthcare. When a woman is, what they say, choked, what they mean is strangled. That is a huge medical issue, life-threatening. And it has to be recognized very quickly, or that woman, man, or child will go home and die. We now are doing research on traumatic brain injury, which is also part of strangulation. And the irony of it all is, if you're Connor McDavid and you get banged on the head, you go into a concussion protocol. If you're a woman or a child who gets knocked into the wall, you probably don't even go for care because it's so common for you. So when we look at the broadness of medical care, I think that my mandate has always been doors from the community open inward, medical open outward. You need both. So as we go along and build all these different entities, we need to talk to each other. We need to understand each other. And we have to look at the history, because who remembers what it was like before? Only the healthcare providers who still are working when they should have been retired 10 years ago. So death doulas are one thing. Looking at head injuries, from strangulation and traumatic brain injuries, looking at home care where there are different entities that come into the home rather than going to a physical place, like going and getting your home care rehab. Also looking at patient navigators. Are you familiar with the term? Yeah. So, okay. So that's something that really needs to come into healthcare and community quickly because my family still doesn't go to the hospital without me because of that. It may be unsafe. And that's a really, really sad state of affairs. So, outreach both ways.
I don't have too much more to add, but I think what I'm thinking about is just about the democratizing of healthcare. I think about it in the same way that we are kind of letting police officers know that they might not be the best for the whole range of actions that they're taking. And so how do we um, place care where other folks can take care of it so that emergency departments can really hone in on and specialize on the things that they do need, like strangulation or acute injuries, and that much of the other care that folks need can be taken care of by people that do have passions around that. As Sheila was saying, oftentimes, people are not necessarily playing to their strengths in healthcare settings, and that can also burn people out. We know that, you know, suicide and self-harming and addiction are all really incredibly high when folks have so much responsibility, and healthcare providers are part of those groups of folks across the spectrum, right? The hours that nurses alone are expected to work in areas that they may not have passion for. I think when we democratize the ways in which people can access care, we also democratize the ways in which healthcare practitioners can actually practice in their strengths and be amongst people who can support them as well, right? Because we can build communities of practice that actually fill our own cups as practitioners, as well as providing the best services possible for folks and population
A
that
huge
need care.
place for that crossover in caring and understanding. And yeah, it's critical incidents happen everywhere,
Yeah,
and yet they're not acknowledged.
yeah, yeah,
And yeah,
yeah. Thanks.
Thank you. Um, so I want to move on to our next question. If we look outside the current medical system, what does inclusive healthcare look like? So maybe Dahlia, I'll start with you this time.
Thanks. Yeah, I think that as an organization at Salal, we've done lots of work to continuously be asking ourselves, who have we created space for? Who feels like they can access our space? Who doesn't feel like they can access our space? And that goes for survivors accessing our services, but also for staff members wanting to join our team. And I think as an organization that hires predominantly survivors also, we know that it's the same in the medical system, right? We all access the medical system. We're all humans. And so how are we also looking at creating spaces where healthcare practitioners are feeling like they can show up as their full selves and be cared for in ways that are caring and non-judgmental, and therefore actually provide them with the ability to provide the care that's needed and that is also inclusive. Because, as Tenzin was saying, oftentimes when we're influenced by the systems, and if those systems are rooted in colonial and or dominant kind of values, it can also eat away at our ability to show up in the ways that we want to and offer the care that is required of us. And so when I think about a medical system or healthcare that is inclusive, it actually means that everybody in those spaces is actually able to feel like they're able to provide excellent service because they are also being treated in a way and held in a way that sees them as fully human as well.
When I look at the medical system and see it in inclusive, I see it as much different than the patriarchal system that exists and has existed. I do see that it has changed. Um, I see physicians speaking out of. Um, I'm looking for the right term here that is politically correct. Speaking out against the factors that control the medical system, because in reality, the medical system doesn't control itself. It's based on financial money, which is being misused in ways, and the political system of the day. And I don't mean just British Columbia, I mean all across the world. So I see that an inclusive healthcare would look like something that where the focus goes back to World Health saying everybody deserves to have violence and trauma treated by a coordinated system. And what would it look like? It would look like the hospitals, or what we would call acute care, would deal only with the most seriously ill. And then other entities might be picking up, it's happening, but it's not happening quick enough, is addictions. We now have addiction houses. Well, there should be, the healthcare dollars have to go out there too. And but it's also that I can say what my community needs, but I cannot say what Tansen's community needs. That it has to be individualized. And we only have 5 health regions in British Columbia. They're all extremely different. And so one size does not fit all. And, telehealth may be the answer for rural areas. That's what Interior Health is going to, is telehealth. But whatever meets the needs of the individuals who we're all trying to provide service to. And I think we're all in the business of being caregivers. And the one person we forget about, as I think Delia said, is caring for ourselves. Ethically, we all need to care for ourselves so that we can care for others. And that's kind of where I see inclusive healthcare, caring for the individuals in it, but also the individuals who access care for whatever reason. It could be done if we all worked together.
Yeah, I really appreciate kind of the different perspectives I'm hearing, and thinking about inclusive healthcare more broadly as well, in terms of health as, if we're thinking about larger human rights framing, health as a human right, health, inclusive healthcare as something that extends just beyond our understandings of physical and mental health, but also to include things like housing, which are so important in terms of whether you're able to have ID to access certain health care, and even thinking about people who experience sexual violence, and having in unstable housing and being housing insecure because of fleeing from violence, and so all of those different things as being important components of what inclusive healthcare should look like, I think is really something I've drawn out of these conversations.
Yeah, I really love kind of what you all shared in terms of how, it's really important for us, I think, as service providers to also think about um, how we're adopting these frameworks, like as an organization, and how we can make that shift. So I really love that. And I think at Salal especially, like we are trying to, like exactly what Dahlia said, just really trying to adopt that, not just like with the people we serve, but also making sure our organization is a place where people feel safe to come to work, because that allows us to really center survivors in our work. Yeah, and take those steps in terms of shifting society. So thank you all. Um, we're coming up here on our last question of the day. So the last question I want to ask all of you is, what practices can the industry adopt to retain queer, trans, and BIPOC medical professionals? So Tenzin, maybe I'll start with you this time.
Sure. I'm going to start big and say free education for all. And, kind of drawing down from that, everyone needs the resources to actually even participate in this system. So if that's something that, if people are given the actual access to those resources, then that might be something that is actually possible in the future. But I mean, when you think about even just the small things like MCAT fees being over $300, 300 US dollars every time you take a test. And that's just like one small component of it, beyond all those other things you need. But even thinking about, you know, across the medical professions, I'm sure over the last few years, a lot of, all of the people who would be considered marginalized in these industries have been brought into, all these EDI committees and, um, you know, anti-Black racism, anti-Indigenous racism kind of committees that, really valuable information is being shared in them by those people affected. And yet it's just kind of lip service of those changes aren't actually being implemented. So across from trainees to students and learners to actual professionals, like those who have those experiences, who are queer, trans, BIPOC, and are in those professions, actually implementing the changes that they see that are needed within the systems, I think is a good place to start. Yeah, beyond just holding a bunch of meetings and with, producing recommendations and then not actually acting on them.
I think the first thing I would say is stop looking at credentials. That doesn't equate to the knowledge and skills that you have. Utilize, and you really hit something, Tenzin, when you said lip service. Well, again, going back to an individual champion, and I say this because in 2008, I asked a trans a woman who transitioned to a male, and I had met him somewhere, don't even remember where. And I said, "Come and teach my class." And he said, "Well, me?" I said, "Yes, you." My class of nurses and police officers, there was a couple in that one, and a couple of social workers. It was a forensic nursing course. And they were blown away by his openness, his ability to articulate the process mentally and physically, so that they could understand. He has basically gone across Canada doing the same thing and is now working in Toronto with his own center of education. And we kind of chuckle because nobody ever thought that an accredited course could have someone who had a life experience. And that's one of the values that I want to bring in here too, is the life experience that the individuals that you may work in the community and how powerful their messages are. And so you need to, thank goodness that they have the ability to speak and share, because it causes them suffering and pain. So I think the first thing that the medical system in any of the entities identified is to learn and understand so that they can change. And by changing, they can be more receptive to students who come in and who may not have disclosed whatever, and say, come on in. Let's bring you in so that you can share the work. And maybe even special facilities. Not that you want to differentiate individuals, but put that into all healthcare education, all community education for social workers, community workers, you name it, because that's where trans, queer, any of the credentials and the initials, and I always get them wrong, so I can't say them all. But I do have a really good book about elder folks that is just released, and I'm going to take a moment. It says Elder Abuse in the LGBTQ2SA plus community. If you want to know about it, I can share it with you. So I'll put my email address in the chat. So that's what I see. I like the free, but we also have to step out of the box and let individuals with life experiences come in to share realistically, not at the grassroots level, because it'll be, oh yeah, thank you, goodbye kind of thing, but at the levels that are going to make that difference. And that's what we also need, is we need medical professions to step out and share. What is their designation? It's not unique in any profession in the whole world or any. So why is it still closed?
Oh, Sheila, I think you're cutting out. Oh,
She disappeared. Maybe her internet went out. I'll jump in here. I love the free education piece. I think that's so important because that is such a gatekeeping piece for so many folks. I think additionally that some of the systems and policies are needing to change. So people's benefits, for Indigenous folks to be able to take time off during ceremony season, for people to be able to have days off that matter to them and their families and cultures, for benefits to line up to make sure that folks can do things to align their identities with their bodies and all of those pieces. Even forms, right? When we're filling out forms, if you're hoping to hire trans or queer people and you've got emergency contacts, we have to start thinking about families that might be poly in addition, different gender identities. Do we even have forms that allow people to see themselves in their workplace? And then I think also addressing just lateral violence within conditions that have traditionally been so scarce, right? Also creates environments where folks don't feel like they can stay. And so, yeah, I think, again, just like systemically, I think it's important for us to think about who historically has been chosen or who have been seen to be valued members of medical communities, and not just who was able to go to school. Because I used to work in the tourism industry at a hotel for a long time, and most of my colleagues who were working alongside of me were doctors and nurses and practitioners within the health industry in other countries, and were not seen as valuable here. So I think it's about how we and the medical system, um, kind of value people's full humanness or not. And all of those pieces, I think, contribute to folks being able to stay and tolerate environments that don't feel generative or life affirming. And we spend a lot of time at work. And for healthcare practitioners, it's probably like normal people times three, the amount of time they spend at work, and in education and all of those pieces. And so I think it's even more important that the environments that people are working in um, are affirming places for them to be who they are fully, but also will contribute again to the care that people are able to provide and receive.
Thank you so much to all of you. I think a big theme or takeaway that I'm really taking from that is just the reliance or over um, kind of inflation of like Western education and how that really has dictated who can even participate within the medical industry, industrial complex kind of as it stands currently. So yeah, thank you all so much. And we're coming to the end of our panel today. So I just wanted to thank all three of our panelists today, Tenzin, Delia, and Sheila, for joining us today and just bringing so much knowledge and insight. You all have such a wealth of experience, so I just wanted to thank you all for sharing that with us today. And I just wanted to remind folks that if you want to connect with us here at Salal, that our crisis and information line is available. I believe the number is in the chat, and then our website is also there as well. But yeah, I wanted to thank you all for joining us today, and I hope you all have a wonderful Sunday afternoon.